Today, we're talking about self-managed abortion. I'm Joyce Capiello, and I am Professor Emeritus at the University of New Hampshire. I taught nursing and nurse practitioner students for most of my career. I've worked in a variety of settings as a nurse practitioner, private practice, FQHC, and for many, many years at the Lovering Health Center, where I provided sexual and reproductive health care to both men, women, and other genders. And I would like Julie to introduce herself.
Hi, I'm Julie Jenkins. I have a doctorate in nursing practice. I have been a sexual and reproductive health nurse practitioner for almost 20 years now, and have worked in various settings and with various populations. I am now working for the National Abortion Federation as the Clinicians in Abortion Care Strategist and Training Program Manager.
Thank you, Julie. So let's get started. First, the required slide. We have no ethical or financial conflicts to disclose today. We do, however, want to disclose that we support reproductive justice, and all this underlies all of our work and our presentation today. So what do we mean by reproductive justice? We use the definition of the human right to maintain personal bodily autonomy, to have children, not to have children, and to parent the children we do have in safe and sustainable communities. This term, reproductive justice, was coined in the mid-90s by 12 Black women who gathered in Chicago in advance of the International Conference on Population and Development in Cairo. They recognized that the women's rights movement, led by and representing middle class and primarily wealthy white women, wasn't meeting the needs of women of color and other marginalized women and trans people, and that they would need to lead their own national movement to uplift the needs of everyone. Any conversation about access to abortion is inherently part of a broader discussion about the ways that barriers to care disproportionately impact people of color and other marginalized communities. Mainstream movements have focused on keeping abortion legal as an individual choice, and that is certainly very necessary. But even when abortion is legal, there are many barriers to many people. And if there's no access, there is no choice. And we'll be discussing this more as we grapple with some of the post-Roe reality, but it's important to recognize that for many people, they really did not have good access to abortion care. Reproductive justice, oops, how did that happen? Isn't only about abortion. It's regarding a number of things, and there's a listing here: environmental justice, gender identity. I'm not going to read them all because you probably have been reading them, but we're interested in this intersectionality of how all of these factors impact a person's access to care. So our agenda today, we'll talk about terminology. Even with healthcare providers, the terminology around medications with abortion and other medications that are on the market that are not abortion patients can be quite confusing. We'll talk about background and trends in abortion care, the effect of the pandemic on abortion care. Like all aspects of care, we had moved to telehealth and how that worked out and how that is impacting care currently. And then we'll talk a bit about scope of practice of nurse practitioners, because normal scope of practice laws at the state level are overlaid by abortion scope of practice. So if you have full scope practice in the state, it doesn't necessarily mean you have full scope provision of abortion services by NPs. We'll talk a bit about the effect of the SCOTUS decision, so the Supreme Court of the United States decision. And then we'll spend time talking about clinical implications for APRNs. So we have some case studies to go forth, and then looking at what's the future look like. I'm not sure we have a crystal ball, but self-managed abortion. What do we mean by that? So it generally refers to any action to end a pregnancy that's outside of the healthcare system. So this is not a new phenomena. prior to the legalization of abortion in our country, there was a lot of self-managed abortion. I mean, there were a few sort of courageous physicians who were providing abortion under the radar screen, but in most situations, it was a mix of other things. There were some lay people who had good training with providing safe abortion care. Think of the Jane Collective in Chicago. But there were many providers, as we know, who were not safe providers and contributed to significant morbidity and mortality during those years. However, things have changed with the introduction of misoprostol and mifepristone. We did not have the approval of mifepristone and misoprostol for medication abortion until the late 2001. So it was really 2002 before providers geared up to offer this. This was way behind many of our European colleagues, but it was tied up in politics, as often is the case. The advent of these medications has been helpful in reducing worldwide morbidity and mortality. 97% of the unsafe abortions currently occur in countries that do not have a structure to provide legal abortion and do not have any system for the people in the country to access misoprostol or either of these medications. Generally, the medications are quite safe, and we'll talk a lot more about this. So let's step back and say, why do women choose medication abortion? And in the next slide, we'll talk about why women choose self-managed abortion. So I did my PhD dissertation in the mid-2000s. So I collected data between 2005 and 2007. So that was shortly after the country was gearing up with medication abortion. And at that time, women told me that the overall arching theme of this qualitative study is that women appreciated the sense of personal control. They liked choosing a natural process. Now, it really wasn't a natural process, but because it was a miscarriage-like event, everyone could kind of wrap their brain around that and think about what that would seem like for them. They wanted to avoid surgery. I put surgery in quotes because it's a term we're trying to get away from in talking about types of abortion procedures. The word surgical abortion, I don't think, has served us very well. It's a very intimidating kind of term for anyone who's thinking about an abortion. And it's not been helpful when we're looking at scope of practice issues at the state level, because legislators say, well, it's surgery. Nurse practitioners don't do surgery. Well, it's not really surgery. It's a suction aspiration procedure. So some people are using the term just suction aspiration, and others have moved to procedural abortion, but you'll see those terms more common in the literature. And then this term, respecting the baby, you might think that was a kind of interesting in that women were terminating their pregnancy, but everyone, and these were all women who were early. I didn't have anyone beyond 8.5 weeks at that point. We now do medication abortions up to 10 weeks, and other places in the world do it up to 12 weeks. But women were very clear that they were ending a pregnancy and a potential baby, and they saw medication abortion as a gentler way, therefore respecting that baby. And they certainly appreciated the scheduling issues, so the flexibility that came with doing this at home, and appreciating that home setting, that non-medical setting for having their abortion. Currently, medication abortion accounts for about 53% of abortions that are performed in the United States. That's not counting self-managed abortion. And that comes from the Guttmacher Institute data at the end of 2022. So the next slide is going to talk about why women choose self-managed abortion. So we have some studies that have looked at this. Some of it is logistics, it's access. If you're in a state where there's very limited access for abortion of any kind, you may have to travel quite a distance. That means finding transportation. Might mean you have to stay overnight. You might have to stay at a hotel. You might be going to need childcare. You're going to have to take extra time off work. And then just the cost of all of that adds up. So there's a Guttmacher statistic, and this was prior to the fall of Roe, which said that 90% of the counties in the U.S. did not have an abortion provider. So this is real. Women are traveling distances. Some people have trouble finding a clinic. In some states, there's waiting periods, which means you have to go and have your history and physical and all of that and sign the consent form. And then you have to come back in 24 hours. So wherever you had to travel to, you have to wait. And there may be specific ultrasound requirements around that. But aside from the logistical reasons, women have in the studies have shown that they prefer the privacy of it. They like being in their own home out of the medical environment. And many people have preferences for self-management. So, this belief in self-care gives a sense of autonomy. So that's been very helpful with this. Further studies have suggested that racism and history of medical abuses is also a factor for many people. So Altman and colleagues found that implicit bias, judgment, and power dynamics experienced by people of color in other aspects of reproductive care translated to how they thought about an abortion. Particularly, this data was from pregnancy and birth. So if they had experienced structural racism in the healthcare setting, they look for ways to avoid the healthcare setting for all types of healthcare. And specifically here, we're talking about abortion. Before we get to that, after the SCOTUS decision, Texas was one of the largest states to ban abortion. So it was a bill called SB 8, and they banned abortions after 6 weeks with very few exceptions. And that pretty much eliminated abortions for most women, because many women don't know they're pregnant, or if there was a heartbeat, they couldn't have the abortion. And there's a group we'll talk about later in greater detail, but Aid Access, not an HIV organization, but an organization to aid women with medication abortion at home. And they found that requests to their service went up 245% in a couple of weeks after SB 8. That same thing was noted across the country after the Supreme Court decision. So there were large increases in calls coming from states where there were now abortion bans, and also in states where women thought the laws may change, and even in states, not as much, but even in states where the laws were pretty solid. People are just worried. So the World Health Organization promulgates abortion care guidelines, and they release these every couple of years. The most recent one was in 2022. And I wanted to read you this statement about self-managed abortion because they have a pretty powerful statement about it. They said self-management should not be considered a last resort option or a substitute for a non-functioning health system. Self-management must be recognized as a potentially empowering and active extension of the health system. Health workers should recognize self-management as a legitimate pathway to abortion care and should work to adopt health systems to facilitate and support women in their self-management of abortion. So, pretty powerful statement from the World Health Organization. I'm going to turn it over to Julie for a few slides.
So abortion medication, how do abortion medications work? Misoprostol is a prostaglandin analog that causes uterine contractions to expel pregnancy tissue. It can be used alone to induce abortion, and efficacy rates in the first trimester were thought to average around 80–85%. However, a new study by IBIS Reproductive Health, the SAFE study, suggests rates can actually be as high as 98%. Much of that is about the timeline for completion. With meso alone, that timeline is longer, and thus in higher resource countries or settings, folks tend to go into care, for care prior to completion, because the process is not as clear cut as it is with mifepristone and misoprostol, and so people get concerned that they're not completing this process, and at that point it's considered a failed intervention. Misoprostol only is the most common self-managed abortion with pills worldwide, whereas in the U.S., mifepristone and misoprostol is the most common. Mifepristone blocks the action of the hormone progesterone, which causes the uterine lining to shed. So when used in combination with misoprostol in the first trimester, efficacy rates increase to greater than 95%, and fewer side effects are reported. The course of the abortion procedure is actually more, you're more able to track it as well. It has a much more clear-cut course. And so while I used misoprostol first, mifepristone is the first pill in a mifi and meso combined regimen that one would take, followed by the misoprostol anywhere between 6 and 48 hours later. And it depends on which route, and vaginal route, buccal route, or sublingual. So what the timing of those interventions are. When approved guidelines are followed, the risk of serious complications, which are defined as requiring hospitalization for infection, treatment, or transfusion, is extremely rare, less than 0.4%. Mifepristone has a safety record comparable to Tylenol, which you would not know if you just listen to the general information out there about abortion with pills. And I think it's always important to remember that childbirth is approximately 14 times more deadly than abortion in general, not even specific to abortion with pills. So when we're talking about the safety and efficacy of abortion, it's important to remember that it is much safer than continuing a pregnancy. And here you can see the rates of medication abortion increase from the early 2000s to 2017, where they do account, where they accounted for 39%, and then in the pandemic where the increase went to 54%. So now it's more than half of the abortions in the United States. So the medication abortion experience, what can people who are going through this expect? So heavy bleeding, cramping is to be expected and is within normal. Oftentimes you'll see bleeding described as a side effect. It's not a side effect, it's the expected effect, right? So so this is what we want to see. There's no way out without having that bleeding. Nausea and vomiting can be common in the first 24 hours after taking misoprostol. There can be large clots, which can be scary for folks. And even though that's quite normal, clots are not fetal tissue. Oftentimes people will think that they're fetal tissue. They're just that lining of the uterus. So it's really important for your patients and for people who are going through this to understand what is normal and what isn't. And there are some great resources that can help with that. And we cover some of that later on in this presentation. Warning signs can be heavy bleeding, saturating of pads. We're going to explain that later. It's also important to note that breastfeeding is not a contraindication to medication abortion with MIFI or meso. And patients should be informed that breastfeeding can continue uninterrupted without concern for side effects. IUDs should be removed prior to a medication abortion. And so that is one of the things to know. Also porphyria and some non-steroidal and some medications can be a contraindication, but there are very few contraindications. And non-steroidal anti-inflammatories such as ibuprofen are often used for pain management and are more effective than acetaminophen for that pain management. So the pre-pandemic trend, and you can see here, and Joyce talked some about this, about the online searches for terms related to SMA and the number of people who reached out to aid access prior to the pandemic. And then you can see that there was a pretty significant increase in consultation requests in April of 2020, beginning during the pandemic. And then during Dobbs, after the Dobbs decision, the increase for providers was significant. It was like a 200% or over 200% increase in the first few days after Dobbs. So what was the common additional testing for medication abortion pre-COVID? Ultrasound was required for gestational dating. RH typing was generally done, hemoglobin, and then a follow-up ultrasound. So multiple visits and in-office visits. And then what we saw, even though we knew about the safety, we knew about the safety from other what was happening in other countries and from people getting care in other countries without and for people having self-managed abortion with pills in other countries, that that was safe, and that ultrasound for gestational dating wasn't necessarily required, but we had not been able to make any shifts here in the US. And then during COVID, we did see many clinics making that shift because it was safer to shift to people being able to either pick up their pills in the clinic or eventually get their pills mailed once the REMS allowed for that. And so we saw some of this shift, and immediately people started to do the research and really evaluate the findings for all of these clinics that switched to pill pickup or mailing of pills. And so we were able to see that ultrasound for gestational dating in the case of a known LMP. So if people are able to really evaluate that they have a known last menstrual period, this is a very effective way for people to use the pills. And RH typing, the guidelines for that have continued to increase. Hemoglobin, there is now, unless people have a history of a problem, they don't need hemoglobin testing. A history of anemia, they don't need hemoglobin testing. And if or unless they're having current signs of having a problem for anemia. So there's just a lot of evidence that has supported that in the last 2.5 years, and we just keep having more and more of that coming up. And that really did open the door for self-managed abortion and for people to really realize that this is safe for them to do at home, because they were doing that when they were getting their pills from clinicians and still doing that when they're getting pills from virtual telehealth providers. So this was some of the way in which, after SB 8, the travel to a clinic went from 12 miles to 243 miles, and it's increased since the Dobbs ruling, because there are a number of states around Texas where people were traveling for care where they still can't get care. Although I do want to point out that Colorado and New Mexico are still sites for people in Texas to get care. And so, we can see the erosion. How did COVID impact abortion care in the US? It highlighted the vulnerability of abortion care. It forced states to define essential versus non-essential services. So they were being defined as, some states were defining it as non-essential, and then, there was a change in that. Expanded discussion of telehealth for abortion. And so some of these virtual clinics were, after in-person clinics started to do virtual care, there were virtual clinics that picked up that and continued to do that. So those are just online clinics. The REMS changes, the risk evaluation and mitigation strategy changes, pills had always been mifepristone had always needed to be picked up in clinic and dispensed in clinic. And for a while by providers specifically. So like a provider would have to present the pill to the patient. And so that was changed, and pills were able to be mailed during the pandemic. I think it was December 12th of 2021, that rule change was made permanent. And so pills were able to continue to be mailed even outside of the public health emergency. And those rules have just been refined in the last few weeks. Some of you may have seen that there are pharmacies that are going to carry pills in communities. So up until now, it has only been the mail order pharmacies, which would be Honeybee, American Mail Order Pharmacy. There's one other called Manifest, I think. But now we will be seeing which pharmacies will be providing in their own communities, and CVS and Walgreens have both said they would do that. The rollout is going to take some time. So allowed for an update of abortion protocols to reflect only essential aspects of care. So as we talked about earlier, not required ultrasound. Ultrasound is only required if you cannot figure out pregnancy dating in some other way. RH and hemoglobin and follow-up can be done with a pregnancy test at 4 or 5 weeks. And we'll talk a little bit more about that later as well. So we learned that people could safely self-manage their medication abortion process, and that really did open the door for people to think about doing this by self-sourcing their pills or in other ways. So this is a slide that talks about that we can really look at the states where advanced practice clinicians such as nurse practitioners, physicians assistants, and nurse midwives can provide different types of abortion. There have been many changes since the last map in 2018. In early 2019, NPs and PAs could provide medication abortion in 9 states and both in 7 for a total of 16. In the past 3 years, we've seen changes from 7 states to 20 for both procedural and medication abortion. And this past year alone, Maryland, Minnesota, Connecticut, and Delaware all shifted and changed their laws to procedural and medication abortion provision for APCs. So this map is constantly changing, and we hope it continues to do so. But it is important to note that any of those red or banned states, nurse practitioners and PAs, CNMs are not providing that care. So in addition to unnecessary testing, there are multiple legal barriers in the US that prevent expansion of medication abortion services. Some of those barriers, as I discussed in the previous slide, 29 states, even with the changes, 29 states still require that provider dispensing medication abortion be a physician, despite the ample evidence that we have that nurse practitioners and physicians assistants are well equipped to manage the care of these patients. And that's through ACOG and APHA, the World Health Organization. 18 states currently have laws that specifically ban abortion via telehealth. And those barriers disproportionately impact Black, Indigenous, and other people of color, people with a low socioeconomic status, or from rural communities. Threats of criminal action against individuals who choose self-managed abortion. Arrest in the US has almost entirely been second trimester. People who have used self-managed abortion with pills in the second trimester. 21 of individuals have been arrested using mifepristone and misoprostol, or helping others use mifi and miso outside of the healthcare system. And many have been turned in by healthcare providers. And we're going to talk a little bit more about that later as well. I think we also always think of states where that's an issue being more of those red states, but the first person to be arrested in the U.S. was actually in Massachusetts. 5 states have specific laws that criminalize self-management of abortion: Idaho, Oklahoma, South Carolina, Arizona, and Delaware. And it's important to know that self-managed abortion is not illegal except in those few states. And there is also nothing illegal about buying medications on the internet. It's legal to import up to 90-day supply of medications. And here we have an up-to-date listing of state laws and a state legislation tracker of major developments in sexual and reproductive health. So trends, pandemic changes, no-touch medication abortion, and that's what we were talking about with not needing that ultrasound, not needing people to come in and get care in the clinic necessarily. That's what we called it, was no-touch medication abortion. Studies have continued to support that there's a great benefit and no harm from providing services in that way. There was the recent FDA decision to allow pharmacies to dispense mifepristone, which I touched on. The Turnaway study is a study that looked at the long-term follow-up of women, specifically women in the study, denied abortions and found negative social outcomes for that. Access to quality to abortion, contraception, and maternity care is possibly improved in influx states, states where they have made some changes to laws that have improved access to medication abortion, and health and social inequities are exacerbated in restricted states. So what we've found is that when abortion care is restricted, research demonstrates that other pregnancy care also suffers, and often miscarriage management suffers, because these are often this medication is often used in the medication management of miscarriage.
Thank you for that, Julie. So let's talk about Roe versus Wade. So June 24th, that was the day when there is no federal constitutional right to an abortion any longer in this country. So the decision shifts shifts it to the state. So state legislators can now regulate abortion without any federal guarantee. Many states had some what are called trigger laws. So the law was already in the books that if Roe should fall, then the abortion ban would automatically take place. So that happened in a handful of states. There is talk, I think it's a little bit of irony, because the Supreme Court decision said this should really happen at the state level. But soon after that, within a matter of days, there was talk about passing a federal 15-week abortion ban. We haven't seen any significant movement with that yet, but I'm sure that we will see some proposed legislation in the current Congress. And I wanted to show you a map of abortion restrictions in the United States. So this is accurate as of September 30th. So there, of 2022, there could be some shifts since then. So I'd like you to focus first on the dark red. So these are the states, there are 13 states that have total abortion bans. And you can see they're mostly in the South, with a few clusters elsewhere in Idaho, South Dakota, and Wisconsin. The blue, the darker blue, is places where abortion laws are very safe. And those are the coastal areas. That's New England, and that's the West Coast. And then, kind of in the Midwest, you see safe for now trends through there. So that's just where we are as of now. And there's some overlay with this map around the APRN scope of practice too. That's been a difficult sell in our southern states. So let's talk next about what's going on specific to an abortion in abortion laws in New Hampshire. So we've always had limited Medicaid funding for abortions. We're not a state like Massachusetts does have Medicaid funding for abortions. We have it for a few exceptions, but they're quite narrow. And I think most providers don't bill Medicaid. The reimbursement's quite low. There's privacy issues. So for someone who's having difficulty with the cost of an abortion, they look to abortion funds. So the next thing I want to talk about is parental notification bill. It was finally passed in 2011, but attempts were made starting in 2003. So the bill that was passed in 2003 said that parents must be, or a parent must be informed of the abortion prior to it being provided. So not parental permission. And there was, I think it said guardian in there, as well as there wasn't a parent. So that got passed, but then parts of that were found to be unconstitutional. In the case of Planned Parenthood of Northern New England versus Heed, that decision that it was unconstitutional was affirmed by the First Circuit of the Court of Appeals. And then the case went to the US Supreme Court, Ayotte versus Planned Parenthood of New England. Eventually, the law was repealed by the legislature while that Supreme Court case was in play. So let's see, how did they say it? It was, the case was dismissed as moot at that time. So then the New Hampshire legislature enacted a new version in 2011, which says if you're under 18 and never been married, And just as an aside, at that time, the age of marriage was 14 in New Hampshire, has been adjusted up to age 16 a couple of years ago, and they were not able to get that up to age 18. So this law requires parental notification. It does have a judicial bypass, but of course for minors, that's a very intimidating process to go through the judicial bypass, although there are lawyers in the state who volunteer their services if someone wants to go that route. Then the next significant restriction in abortion care was in 2021, and this was the Fetal Protection Act. Now, it was interesting how this was passed, because most bills are introduced either in the House or the Senate, and there's a chance for residents of the state to talk to their elected officials and to lobby about their position on it. But this bill, this act, just circumvented all of that. They placed it in the budget. The budget went to the governor. The governor could approve or not approve the budget, could not do a line item with it. And the governor's felt that he had to pass the budget and not hold it up. So the restrictions in this act were quite significant. It restricted all abortions to 24 weeks and under. So for the cases of fetal demise and serious fetal difficulties, there was not an option for a woman to terminate a pregnancy after 24 weeks in the state of New Hampshire. It created a Class B penalty for providers. And this was 7 years imprisonment and financial assessments of $10,000 to $100,000. And it's the first time we've had restriction on healthcare or criminal restrictions on healthcare providers. It also made it mandatory to provide an ultrasound for anyone procuring an abortion. So essentially that meant telehealth was not very feasible, because if there's a woman who actually needed an ultrasound, and it just didn't work anymore. So in 2022, that legislation was amended. There are exceptions for fetal abnormalities incompatible with life after 24 weeks. And the mandatory ultrasound is now written that this occurs around 24 weeks. So if you think the woman or the person is around 24 weeks, you need to do a mandatory ultrasound at that point. So what's going on related? The Executive Council has voted to not accept the full amount of federal family planning dollars that come to the New Hampshire Family Planning Program. You might think if you wanted to restrict abortions, you would actually make contraception easier to obtain, but that has not been the viewpoint of our Executive Council. This has been done a few times before, 2011 and 2015. But 2016 until this past year, the executive councils have always voted to approve those family planning dollars so they could come into the state. So we shall see what happens in 2023. In 2023, there was a Reproductive Health Act that would help to codify Roe within the state legislative regulations. That did not pass. I assume we'll see some version of that come forward in 2023. In 2023, we're also going to see a way to codify reproductive autonomy in the state constitution. Now, that's a heftier lift, because you need 2/3 vote, 3/5 majority of both the House and the Senate, and then it needs to go to the general public on a ballot. So it faces a difficult path, given the current legislator and just the current climate in the country. So you might think that New Hampshire is seeing an influx of women coming from southern states who are seeking abortions. It's not what we've been seeing. So we have been seeing women who've come from states with restrictions, if they've had a connection to New Hampshire. Maybe they have family here, friends here, they used to live here, something like that. Or we've also seen people coming from neighboring states if they can't get an appointment and we have openings here. We were seeing that, but we've not seen a lot of women coming from the restricted southern states to New Hampshire. The thinking is they're going to New York City. It's a more diverse place with healthcare staff that are more diverse, and that might feel more comfortable to people coming from those states. So how do people access abortion medication? This is just going to be a broad strokes look at that. I mean, right now, pills are very available online, and you can get, safe pills. The ingredients are what they say they are. But, you need some savvy about that. You have to have internet access. You have to know how to do a search. Then you have to have the money to pay for pills. The average cost of abortion medications online in the US right now is about $110, but that is less than a medication abortion in the healthcare system, probably starts at about $500 and goes up. If you're going to have pills mailed to you, you need to have a mailing address. If you're homeless and you don't have an address, if you don't want mail coming to your house, you need to figure that out. You need to have it somewhere else so that you can pick it up. And so you just need a certain amount of savvy to be able to negotiate that. Although for a lot of people, they would rather negotiate that system than the healthcare system. So here's some of the sources for information and for pills. So I'm going to kind of divide that up for information giving and then clinician supported medication abortion, and then self-managed at home. So Plan C is an interesting website. It's a very robust site providing information on how to access pills online, depending on your state. So it's going to give information and then send people to various organizations depending on their state. And then they'll go to that site and there will be a clinician supported person, so that somebody's going to take their health history and say, yes, this is reasonable for your health history, and is going to mail them pills. So aid access, remember, this has nothing to do with HIV. This is aid access, provides in all states. And I think we should spend a few minutes talking about aid access because it has an interesting background. This organization was started by Rebecca Gompert, who is a Dutch physician, and you may have heard of her. Through the years, she started Women on Waves. So she would take a ship that was a medical ship capable of providing abortion, set up as a clinic. She would take it to countries where women did not have legal access to abortion. Women would then board the ship. She would travel 12 miles out to international waters where she could legally provide an abortion, and then bring the person back to their country. There were major headlines when she was doing this in Ireland, and that was before the Irish legislature passed laws to support abortion. So then her next iteration was Women on the Web. And this was for countries where she couldn't get a ship to. So if you needed to be living in a country where you didn't have legal access to abortion care, and she would then, do this history taking and assessment online and send the pills to women in that country, and they'd arrive in a brown paper envelope without any markings, and generally would get to the person without sort of under the radar, without being stopped. And then her most recent iteration is aid access, which is specific to the United States of providing abortion pills. And so interestingly, she started this before Roe foul. And you might wonder how that went. So the FDA actually in 2019, because she started doing this in 2018, sent her a warning letter, a cease and desist letter about her providing generic mifepristone. She, in turn, Aid Access, sued the FDA, saying they weren't helping women exercise their constitutional right to an abortion. And the FDA didn't pursue any further legal action against her. And I'm not sure what legal action they had. They couldn't take her license away because she wasn't practicing in the United States. And the evolution of that is they are now providing medication, abortion pills to women in advance of demand. So if a woman says, I just want to have it here, so if I do have an unintended pregnancy, I have the medication to use right away. And that organization has been starting to do that. There are other clinician-supported groups, Abortion on Demand, CareFM, Troy, Hey Jane, Just the Pill, WISP, and there's probably more than I haven't put on here. Some of them are specific to certain states, and that's why something like Plan C can really direct people to the appropriate place for them. And then self-managed at home without any connection to a provider might be self-sourced. So let's say you have family in Mexico and you can buy it over the counter. You can buy mifepristol over the counter. It's an ulcer medication, so it's on pharmacies in many places in the world. In many places in the world, you don't need a prescription to buy medications. So you might ask family in Mexico to buy some and send it to you. So that would be self-source. And then there's a group in Mexico, Los Libros, has been in existence for a couple of decades. And that's because in Mexico, as with here now, it depends on the state. So Mexico City has been providing both types of abortion since 2007, but many states have not. So she has been helping to make sure pills get to individuals in those states where they don't have any access to legal abortion care. And she has started extending that network to the United States, is able to, through kind of her network of volunteers, get pills to volunteers in the states, and then they can distribute them as needed.
I just wanted to mention too that there are some of those other providers who are also doing what we call advanced provision. Choice is providing advanced provision, and I don't know how many of those other virtual clinics are, but that is a thing that is happening. So folks are able to get pills and have them at home for or in their medicine cabinet if they need them. So self-managed abortion resources. So the M&A hotline, which is the miscarriage and abortion hotline, it's a free hotline staffed by clinicians for people needing support to self-manage their miscarriage or abortion. SAS, which is self-managed abortion safe and supported, provides information, resources, and support in using self-managed abortion with pills. And their contact information for all of these are here. ReproCare Helpline is an anonymous helpline that provides peer-based emotional support, medical and abortion fund info, and referrals to people having self-managed abortion at home with pills. And so sometimes the question is, that folks get asked is, what's the best way to use these pills? And we are going to talk more about that as we go forward in this presentation. This is some information for both providers and patients on how you would find an abortion provider, right? So if you had someone who come and ask you, where they could find this information, these are virtual. These provide both of these, I Need an A and Abortion Finder, provide information on both virtual or in-person clinical care. So I Need an A provides information on the closest clinics, including telehealth or abortion pills by mail, if allowed in your state. And they also give information on parental consent laws, on abortion funds, and other financial resources. Abortion Finder provides information on available abortion clinics, including the virtual clinics. So these are great resources to just have for people and to be able to give out to people, as well as whatever your local clinic resources are. Some people would prefer to access care not in their local community, and so that's an important thing to remember as well. Financial resources for abortions and abortion care. The National Network of Abortion Funds is a network of more than 80 organizations. And really what their goal is to remove the financial and logistical barriers to abortion access. And so many of these funds, most of these funds are local funds. So there's one fund in New Hampshire, which is the Reproductive Freedom Fund of New Hampshire. There's one fund in Maine, which is the SAFE Fund, Safe Abortions for Everyone. I think Massachusetts has, I don't know what number they are up to in funds now. I think it's 5 or 6. Connecticut just started a fund. Vermont has a fund. So most of the time, if you go to the National Network of Abortion Funds, you can find whatever local fund is available for folks, and people can use that as a point of entry for figuring out how to pay for their abortion services. There's Apiary for Practical Support, which is similar as a practical support org to the National Network of Abortion Funds, and does a lot of work with the National Network of Abortion Funds. And so the I Need an A is actually run by the National Network of Abortion Funds, and Apiary is part of that. So that's, you get the practical support piece through that. Practical support services such as transportation, childcare, translation services, doula services, and housing if you are traveling to get an abortion. The Reproductive Freedom Fund of New Hampshire, and since ROFEL, the Reproductive Freedom Fund of New Hampshire has funded 100% of New Hampshire residents that reached out and were looking for aid, and 50% of out-of-state folks coming into the state for care. So sometimes abortion funds will work with other abortion funds at the state of entry with folks coming from the state of origination. So sometimes those costs will be split out. The Abortion Freedom Fund is the only national telehealth abortion fund which supports accessible, affordable telehealth abortion. So looks to support all of looks to support abortions happening in those virtual clinics that we talked about. And really works with local funds to encourage those funds to support those virtual clinics, reimburses those local funds for those clinic visits, allowing those funds to keep their own funding for in community, in clinic procedural visits, whether that's medication abortion or procedural abortion. And so that's the Abortion Freedom Fund. Post-abortion support. So there's a few different options for post-abortion support for people who need it. And so if you have patients who come in who are wondering about where they can go to talk with someone, and they just need some to really be able to talk through this, there are these 4 resources. So there's Connect and Breathe, which is a peer-based after abortion non-judgmental talk line. There's Exhale, also same thing. Abortion Resolution Workbook. This is a workbook that you can carry either in your office, or people can go to it online. And it's a guide for those seeking emotional and spiritual resolution. And then there's the All Options Talk Line, which is a free phone-based peer counseling support network. And that is for anyone at any stage in or after their pregnancy. And so those are folks who, this is a talk line that often will discuss options counseling with folks about when people are trying to make the decision about what they're going to do, whether they're going to parent, whether they're going to make an adoption plan, whether they're going to have an abortion. But they are also available for post-abortion conversation. They are also available for folks who have placed for adoption. So they're a great resource for anyone looking to really talk about any conversations around their pregnancy decisions. And this is just a slide that sort of covers a number of those resources that we just talked about, and really just kind of gives what their website logos look like. So that's that slide.
So
And
case studies. So we're going to move into discussing some clinical cases. Next slide, please. So here we have Alexa, who is 19 years old. She's 7 weeks pregnant. She took mifepristone 24 hours ago, and then she followed that with misoprostol. She took that 6 hours ago. And within 4 hours after taking the misoprostol, she began having heavy cramping followed by heavy bleeding. Alexa is not, just as background, is not used to heavy bleeding, as her regular menses are very light, and she was on oral contraceptives with very light withdrawal bleeding. She wasn't able to fill a prescription, which was the reason she ended up getting pregnant. She is saturating 2 pads an hour for 4 hours. She's worried. So let's talk about some of this. Can you go to the next slide? So patient history. So we will assume that in this case, she had some provider input. As Julie mentioned, there are various few specific contraindications to either of the 2 medications. She's not on long-term corticosteroids. She doesn't have severe anemia, and doesn't have an ectopic pregnancy. Patient had been confident in the day of her last period. These are always things a provider would want to know about. She has had the ability to access a medical provider with questions because she came into urgent care, and she's not yet had a follow-up test because she's not yet there. And here's a link to the sample protocol for that no-touch or telehealth abortion. But let's go on. So clinical guidance for providers around clinical bleeding. So heavy bleeding would be defined as 2 maxi pads per hour for 2 hours. So Alexis talks about changing pads 2 times an hour for 4 hours. So we really need to look at that. You want to ask her very specific questions about what kind of pad she is using, so you get a better sense of that. We tend to quantify the bleeding based on the size of a maxi pad. So abortion providers are going to say, wear a maxi pad, initially, and call us if you're saturating a maxi pad, 2 pads per hour for 2 hours. She was actually using a mini pad because she's just not used to having much bleeding. And so she does not meet that criteria for heavy bleeding that you would worry about excessive blood loss for her. So cramping, generally you would expect people to start cramping within 1 to 4 hours after taking the misoprostol. And it may be quite heavy. You would expect it's going to last anywhere from about 1 to 4 hours. And sort of similar with the heavy bleeding, you would expect that range of about 1 to 4 hours, maybe 1 to 6 hours. But at that point, you would expect that people would have passed some clots. They're probably not going to see any tissue. And then things should be lessening. They should be having less bleeding, less cramping. And then over the next day or 2, they'll start to have a lessening of pregnancy symptoms. I think I mentioned we do medication abortion in the medical system up to 10 weeks. Other parts of the world will do up to 12 weeks. And there's certainly been ongoing studies as looking at using misoprostol further along in pregnancy. The other thing you would want to assess for just any signs of infection. Does she have an odorous vaginal discharge with her abdominal pain, or just something that could be sort of unrelated to the abortion but got exacerbated during this time? Next slide, please. And here's a slide that looks at the amount of bleeding. And so if you have someone using a large size maxi pad, you can go through, scant amount, light amount, moderate amount, and heavy amount. So a mini pad, again, would not, saturating a mini pad would not be of concern. And just why we have this slide here, I'll talk about how the medications are used. So mifepristone can be given by the oral route, so people can swallow that. But misoprostol has decreased efficacy if taken by the oral route. So the common routes are buccally. They need to hold that medication in their cheek for 30 minutes. Could be sublingually, but buccally seems to be a little bit easier for people, or it can be given vaginally. So some people prefer to put them in the vagina so they don't have to hold these pills in their cheeks. But it just something to keep in mind if you're practicing in a state that's banned abortion and you're concerned about criminalization of patients. If a person had to go to the emergency room for something, the provider might see residue of pills if they used it the vaginal route. So back to that case study, not concerned yet about that woman. I would reassure her, have her go home, finish that process, follow up with her in about 4 hours, see how she's doing, and then make sure that she's had a negative pregnancy test before she's totally discharged out of your care. So next case, Kelly is 24 years old. She's 8 weeks pregnant. She presents to the ER with vaginal bleeding for 3 days. She's got moderate to severe abdominal pain. So for this woman, you really want to think ectopic pregnancy until it's ruled out. So just a bit of background on ectopic pregnancies for people who haven't dealt with that in a while. Clinical manifestations of ectopic pregnancies tend to occur around 6 to 8 weeks, at least if that's as a ectopic pregnancy in the tube. Sometimes it takes a little longer for presentations that are in other areas of the pelvic because they're not so constrained by the tube. They may be growing before they present with symptoms. A woman with an ectopic may have normal pregnancy symptoms of breast tenderness, nausea, frequent urination, and sometimes not. I mean, sometimes hormonal levels of the progesterone, estradiol, and human chorionic gonadotropins are lower in an ectopic pregnancy, but you really can't go by that. Same with there's no specific pattern of bleeding or cramping that is specific to ectopic pregnancy. The only sort of specific bleeding is a pattern is if a woman has a ruptured tubal pregnancy, she's going to dramatically have pain and be bleeding, into her pelvis, and so she's going to be presenting with a lot of symptoms. So it's usually pelvic pain. It can be on one side, it can be on the other. If it's an extra tubal, like not in the uterus and not in the tube, somewhere else in the abdomen, those symptoms might present with some upper abdominal pressure. If she is bleeding into the pelvic area and there's enough bleeding to irritate their diaphragm, then that person may have some shoulder pain, and that is specific to an ectopic pregnancy in a pregnant woman with bleeding and cramping. So just for some perspective, how often do ectopic pregnancies present? There was a recent study that looked at more than 2,000 pregnant patients who presented to the ER with first trimester vaginal bleeding and or abdominal pain. So of those people who had symptoms, 18% of them had an ectopic pregnancy. So there's lots of other reasons for spotting, bleeding, and cramping in early pregnancy. But of the 18% who are diagnosed with ectopic pregnancy, 76% had vaginal bleeding. So pretty common presentation, and 66% had abdominal pain. So just in general, in women's health care, anyone who's early pregnancy and presenting with bleeding or significant cramping needs a workup for ectopic pregnancy. And usually that's going to be an ultrasound as your first thing. You can do quantitative assessments, but that doesn't give you a value that's useful right away. You get a value, but then you have to do that again in 2 days to see if that HCG is increasing, stabilizing, or decreasing. And so that's not so helpful as an emergency workup. Next case, please. Mari is 30 years old. She's 9 weeks pregnant. She's had no bleeding within 24 hours of taking misoprostol. she has had some light bleeding that's been going on for less than 4 days. She still has pregnancy symptoms. So she has a little bit of bleeding, but it didn't start right away after taking misoprostol. And you would expect in that, 1 to 4 hour period, she would start with some kind of bleeding. So, the concern here would be for an ongoing pregnancy. And if you had point of care ultrasound, so if you had an ultrasound in your office, that would be the best way to start a workup of this woman without ultrasound available immediately. I mean, you would order it. You would also order a quantitative pregnancy tests, again, just to get some sense of trend over time, but it won't give you immediate information. Many providers would repeat her medications, her abortion medications, and that is a reasonable thing to do. Let's go into our next case study, number 4. So she has an early pregnancy termination. She's 25 years old. She had an abortion 15 days ago. So she took the mifepristone followed by misoprostol 2 days later. After taking the misoprostol, she bled heavily with moderate cramping for 4 to 6 hours. She passed clots. The cramping resolved after 6 hours with much lighter bleeding. For the first week, she was changing a moderate pad 2 to 3 times a day. The second week, she was changing a mini pad 2 times a day. And now she's wearing a pad, but she said she really doesn't need it. She's just worried she'll have a little spotting. Her pregnancy symptoms have gone away. The reason she's come in and that she's worried is she decided to do a drugstore pregnancy test and the result was positive. And she says, "Am I still pregnant?" She's not had intercourse since the abortion, so there doesn't appear to be a risk of a new pregnancy. Her plan for birth control is she has oral contraceptives at home, and she plans to restart pills once she gets her period. She could have started them sooner, but she didn't. And on exam, no blood in the vagina, closed cervix, small, firm, non-tender, involuted uterus with no adnexal tenderness or enlargement. Her vital signs are all normal. She's afebrile, but her urine pregnancy test in the office is positive. So what's going on here? Likely, based on history, she has passed that pregnancy. And history is very specific to having a successful medication abortion. What we do know is that some women, the hormones of pregnancy, the HCG, decline slowly. So in 20% of women, they will still have a positive pregnancy test at 4 weeks. And then it declines, continues to decline after that. And that's probably what's going on with her. And we do suggest people wait until 4 weeks to do any kind of home pregnancy test. But even then, we're going to still have some positive tests. So how would you assess this person? I mean, we used to have, and they're still available, except no one stocks them, less sensitive urine pregnancy tests. And there's something called a multi-level pregnancy test that a few abortion clinics might have, but mostly those are not widely available. So generally you're going to, if you've got an ultrasound, you can check to see if there's an intrauterine pregnancy. And we're always cautious in telling people there may still be some endometrial thickness after the medication abortion. That is just an insignificant finding. It should not be used to guide care at all. So that would be one way to assure her. Otherwise, doing quantitative tests, because you should be able to see those levels drop over 24 hours. 48 hours. But you do want to have some contact with this person until you get to a negative pregnancy test, just to be sure. Whether that's as simple as having her call in and give you the results of a home test after you've been sure that she doesn't have an ongoing pregnancy.
So we're just going to shift gears a little bit and talk a little bit about miscarriage management with abortion pills. And so this is just sort of a slide that's for your information about miscarriage management. Miscarriage management with pills has often been done with misoprostol alone. And you can see here that the rates with misoprostol alone is somewhere in the 60s. So there are a few choices, right, for miscarriage management or early pregnancy loss management, which are, and we are shifting to that early pregnancy loss terminology. But it's watchful waiting, so expectant management. It is medication management, and then it is procedural management. And so we have seen a rise in medication management in people who don't want necessarily the watchful waiting. They're not ready to go in for procedural care, and medication management is a really acceptable choice. But some of the outcomes have not been great for folks, and they still end up getting procedural care afterwards. So you can see that the success rates here climb by about, about 20%, whether it's all subcategories, whether it's embryonic demise or an embryonic pregnancy. So what you can also see from this is that there's still people that these are not as effective as the early pregnancy management is not as effective as medication abortion. Right. So there are still a number of folks who are going to need to go in for procedural care, but you can cut down on that number for your patients by providing them with the addition of mifepristone to that misoprostol if you give them medication management. And the use of mifepristone in addition to misoprostol is recommended by society guidelines throughout the United States, including the American College of OBGYNs, the National Abortion Federation, and the Reproductive Health Access Project, and the world, based on numerous recent study findings, both here and abroad, that have just been done over the last few years, honestly. But you may also be aware that there was a petition, a community petition that was done asking for the FDA to change the guidelines for this on the mifepristone label, and they declined to do so. So you will not see it on the label, and I don't think we'll see it being as widely used as it could be until that happens. Here, case study number 5, Anna asks you, her primary care provider, to give her advice as to procuring a self-managed abortion with pills. So I think one of the important things to know here is that giving information to folks is never a problem, right? So if you give them the information about, well, abortionfinder.org is a place where you can find information about where you would go for abortion care. If you give them information about the National Network of Abortion Funds, if you give them any of those sort of websites that we talked about, it can be more complicated with giving medical advice, particularly if you are in states where this is banned, right? I mean, it's more of an issue. It's probably not going to be a problem for you in New Hampshire or in some of these other states. But you need to remember that you are in your role as a healthcare provider. And so if there are laws banning certain procedures in the state in which you're practicing, that can be a legal issue. And so oftentimes the thing to keep in mind is that really giving website information, giving information about how people would take these pills, like what is the safe way to take pills, without recommending that for this person in front of you. And so it often is that sort of talking about this as a third person kind of, this is the way that people would take these medications. This is the safe routes for medication administration, but not recommending it necessarily for that person in front of you. And there are a lot, as we've talked about, there are a lot of self-managed abortion resources that are going to have more information about this necessarily than you do. And so giving folks access to those resources. So avoiding criminalization, be intentional about when you are taking a health history from patients. And this is important to remember too. And this is also more in states where this is more of a problem in banned states. But even in states where we don't see bans, we should be thinking about this. You need to be intentional about the history that you solicit and only gather and document information that is relevant to care. So you don't need to put any more information in that chart than what is required for the person after you to provide care for this person. So if someone tells you that they had a self-managed abortion, and some people will because they're nervous, they're scared, they want to disclose that information, you don't need to write that down. The complications of spontaneous abortion are identical, or early pregnancy loss are identical to presentations of self-managed abortion. You do not need to differentiate between the two, and you could enter in the chart that a patient believes she is pregnant and is now bleeding without specifying specific details about that. We do know that patients are most likely to be turned in by healthcare providers. That has historically been the case, and it's important for people to know that it is a HIPAA violation if you turn in your patients for this. If you have questions, you can, the If, When, How Repro Legal helpline is a place to reach out. They provide free confidential helpline services that gives legal information or advice about self-managed abortion. And they do that for providers. They do that for clinics. They do that for all kinds of folks who need this information. RAP, the Reproductive Health Access Project, also has a emergency, a new national group of emergency providers, and that's run by 2 emergency room nurses. And so that's another place where if you wanted to join that, you could go to the Reproductive Health Access Project and join that group looking at ED services. Reporting mandates vary state by state. So you can see here, these are some of the reporting requirements: child and vulnerable adult abuse, statutory rape, certain traumas and injuries, abortion, and vital statistics. So specifically what that means is that people who are performing an abortion, either giving medication abortion or doing a procedural abortion, need to report that abortion for vital statistics purposes. That does not refer to people needing to report an abortion for somebody who comes in for care, unless you are the one providing that service to them. Self-harm, and in some cases, overdose and drug use during pregnancy. So those are the list of mandated. But as far as abortion goes, no state requires you to report on a patient that comes into your care for a self-managed abortion.
So as we wind down this webinar, I just wanted to leave with that many of you have been maybe sensing some of your own personal tension about self-managed abortion. Is this really something that you think is safe? Why don't women just come to see a healthcare provider? This is a common tension. Studies have found that this is the case. Aiken, again, interviewed providers and staff who worked in abortion care, and they were experiencing this tension. So in her study, people felt that the decision to self-manage was a reasonable one in light of barriers to clinical care and individuals' preference, while others believe that desperation and the constrained choice in states led to self-management. And if people were free to choose clinical care, they wouldn't self-manage. However, we have those previous studies that we talked about at the beginning, where a number of people would choose to not interface with the healthcare system for privacy, because they've had bad experiences, that haven't been treated well in the healthcare system, or they just wanted that sense of autonomy. So our struggle is between our control, where we're used to providing care in the context of a system that we feel is safe, versus that reproductive autonomy that many women and individuals desire. So I just leave you with talking about that tension. It's not unusual. And just thinking about, making sure you kind of keep up with what's happening in the world of research, and also politically around self-managed abortion, and just clarifying your own values about reproductive autonomy. Julie?
So really, when we're talking about the future of abortion access, this is one of the things that we are looking at. We don't know what the future will hold, but we do know that people will continue to pursue abortion as an option because that is what has always happened. And trends show that abortion with pills is an increasingly popular method that patients continue to choose, and that self-managed abortion will also continue to be an increasingly popular choice for folks. Our legal and political environment plus pandemic-related provision of abortion care increased this move towards self-managed abortion, and that's okay. Choices are good, and people can make their own decisions on how to access the early abortion care. This is the safe and effective regimen if people know when their last menstrual period is, if they have, gone to a website and ruled out those few minor or those few contraindications. And we'll take you back to our first slide where we discussed that we had no conflicts of interest, although we alerted you to our respect for patient autonomy in decision making. And that respect for autonomy has made us clarify our values, review the research, and feel comfortable with patients making choices in this issue. And if you have questions or comments, you can email us at Joyce Cappiello joycecapiello@unh.edu, or Julie Jenkins, jjenkinsnp@gmail.com, or jjenkins@prochoice.org. And here is our references and further reading, and this is a doc that you'll be able to access that will take you to a more comprehensive resource list. Thank you so much.
And from Joyce as well, thank you so much for listening. Take care.